Okay, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Sadiq. Dr. Sadiq graduated from Sindh Medical School in 1989 from Karachi, Pakistan. He completed his internal medicine residency at St. Louis University Hospital and then went on to pursue a gastroenterology fellowship with UT Houston MD Anderson and Oklahoma University. Dr. Sadiq has been practicing in Fort Worth, Texas since 2002. He currently serves as the head of the GI residency program at Baylor All Saints Hospital in Fort Worth, Texas, and is an active fellow of the American Gastroenterology Association. He is also the chief of GI North Texas Specialty Physicians. And now it is my honor to request Dr. Sadiq to begin today's session. Thank you.
Good morning, everyone. I hope everyone can listen to me clearly.
Yeah, we can hear you.
Okay. Can you put up my presentation on?
If you click the little green button at the bottom,
okay, there we go.
Click,
yeah. Okay.
Perfect.
Is that viewable?
Yep.
Okay. Welcome, everyone. My name is Sadiq. I'm one of the gastroenterologists here in Fort Worth, Texas. I've been here for a long time and currently serves as an academic chief of gastroenterology in one of the residency program here. Gastroenterology is very exciting, and it was my passion to complete this training. As you know, I am originally from Karachi, Pakistan, where I graduated in 1989. And then there was a long road onwards for residency and then subspecialty fellowship. Got through that eventually and then started working here. I really want everybody to feel comfortable in medicine when you enter in that field. My message to everyone is try not to do what you think is lucrative. Try to do something which is good for you, that you enjoy, that you feel comfortable. Because the worst thing you want to do is something you don't like and you end up in that profession and it'll be a torture for you the rest of the life. So medicine is very exciting and each specialty is amazing. There is no good or bad. It's just what you like to do first is amazing. So I chose to be a gastroenterologist because I enjoy technical aspect of it. I'm very procedure kind of oriented and like to do a lot of things with complicated procedures in hands, and that just is an amazing thing. So that led me to this specialty, and I wish all of you best of luck going through your endeavors. But if you ever choose gastroenterology, there's dramatic changes happening and more advanced procedures are done, and just fascinating to do all these things. Going on to a little bit of a discussion regarding the topic that was given and to share with you guys is heartburn, which is also known as gastroesophageal reflux disease. So I wanted to give you a little insight about what we do here as of that management. As you know, obesity is a lot of problem across the world, and particularly in the USA. And with obesity, there's lots of perks that comes with it, namely heart diseases, diabetes, other metabolic diseases, and of GI interest is severe acid reflux disease. So we manage those across the board and try to help out patients to manage this complicated disease. I want everybody to understand the definitions first before understanding heartburn and reflux. A heartburn is a symptom, basically. It's a precordial or retrosternal burning sensation that people get. It can be from several reasons, not necessarily from acid only. It can happen from alkaline reflux of bile. It can happen from chemical injuries such as pills. It can happen from taking caustic, which are irritating to your mucosas, transferring that. That can result in heartburn. Gastroesophageal reflux disease is actually when your stomach contents reflux into your esophagus. So that actually is a different entity as compared to just the heartburn. So gastroesophageal reflux disease is one of the cause of the heartburn, and not all heartburn are from GERD. So there are a lot of people who have refractory heartburns and not necessarily a reflux disease. So I want you everybody to clear out. So since a lot of you are stepping into medicine world, and you will have lots of family members and friends and neighbors who's going to come and ask your help. So make this very clear that heartburn is one of the symptoms, while gastroesophageal reflux disease is a disease. So there are two different things. Before we dive into the gastroesophageal reflux disease, I want everybody to understand a little bit of anatomy of how the GI works, basically. During the embryogenesis, in which the children and the fetus is made, there is three portions of the GI tract: a foregut, a midgut, and a hindgut. And each of that part of the gut draws its own blood supply from a different part of your circulatory system. So these three part of your gut, foregut, midgut, and a hindgut, eventually fuses together to make one big tube, which is your GI tract. So anatomically, we can divide your GI tract into three different parts. And that also reflects by what blood supply it draws into and which part of the body it draws into. The foregut that we're going to discuss today, which is the proximal gut, consists of your pharynx, the throat, the esophagus, the tube that swallows the food down to your stomach, the stomach itself, and the part of the small bowel, the first part of the small bowel. And this is consistent of a very important digestive tract that basically performs the first function of swallow. Esophagus, after the swallow, is one of the most important organ that has to remain healthy. It can produce lots of symptoms if it's not functioning well. So the anatomy of your esophagus is divided into three parts: the upper part that joins your pharynx, the middle part, which is the tube, and the lower part that joins the stomach. The upper part is basically the receiving end of your food bolus that is being chewed and masticated in your mouth, and then it swallows down into your esophagus. So it receives the food first, and it has different function. So the middle part is basically responsible for propagating the food down into your esophagus. It's amazing how strong these propagation waves are that we call peristalsis. If you have a person who is standing upside down on his head and you make him drink water or swallow water, of course, it'll come through his nose out there, but there will be a portion of the swallow that actually can go all the way down to the esophagus and into the stomach against the gravity because of these contractions are so strong. So those performs a very strong and important part of your function in the esophagus. And then the esophagus distal part joins your stomach, which is what we call it a sphincter. It has a muscle that relaxes with each swallow and facilitate the food dropping down into your stomach to do further digestion. So it has an important function. And of course, when you have an esophagus, a sphincter down in the junction of your esophagus and stomach, which is closed normally, it opens up with each swallow and then closes. Well, if it stays open and doesn't close properly, then we have a problem. And the problem is the stomach contents can come back up in the esophagus and causes damage. One of the most important stuff or the chemical that can come back into your esophagus is acid in your stomach. The esophagus doesn't have any chemicals such as acid or alkaline fluids or anything else. So it has what we call as a sterile milieu, which doesn't have any chemicals, and all your food basically just drops down. But when you reflux the acid up into the esophagus, it shouldn't belong there. And it can cause lots of problems, such as heartburn. It can burn the lining of your esophagus. It can cause scarring. It can cause chronic damage and eventually leads to bad stuff, such as cancers and strictures and whatnot. So I hope that clarifies some of the function of the esophagus that I just told. If you know the anatomy and if you know the physiology of an organ, you can easily find out the disease. But if you don't know the structure of the organ, and if you don't know how it works, then you will just remember the names and it will never help you. So understand the basis first, that, you know, we have an organ that works like this, and then there's an organ that basically is responsible for certain action. And if you damage that organ, how does it work? And what do we do to help? I hope that clarifies some of the anatomy, that you have the proximal esophagus, the middle esophagus, and we have a distal esophagus, or the junction of esophagus and stomach, that we call lower esophageal sphincter. In a short form, it's called LES. And it is more of a functional sphincter, basically. So let's dive into this a little bit more of gastroesophageal reflux disease and see how it works and how does it do. So I hope everybody can see this slides. So again, the definition of GERD is basically, I just discussed, we're going to discuss some of the epidemiology, that how severe it is and how many people suffers from this. We're going to do some of the pathophysiology of the GERD, and then how is the clinical manifestation and what do we do to diagnose it and what are the treatment? And if the treatment is not working, what are the complications? All right, so here's the anatomy. So the definition of the GERD is there's symptoms, which is not necessarily damage, just a symptom, or truly a mucosal damage produced by abnormal reflux of gastric contents. Now, remember that these are not abnormal fluids. They are normal fluids in the stomach, but they do not belong to the esophagus. So that's why they are called abnormal reflux. It should not be a normal thing for the stomach contents to come in the esophagus. But again, acid is good for you. So don't get too crazy about acid that we need to turn off acid. There's a reason nature and God gave you acid, and works very importantly for everyone. So don't go after acid. It does a very important job. But when the acid is in the wrong position, it causes damage. So on this diagram on the right side, you can see the tubular esophagus coming down right there. And then there's the diaphragm, which separates the chest cavity from the abdominal cavity. There's a small opening in the diaphragm through which the esophagus goes down, and it basically joins with the stomach. And you can see little thickening of this muscles, which is up here showing up. And this is what we call as lower esophageal sphincter. There's a little fat of pad and a muscular hypertrophy, which closes this. So none of this contents in the stomach should come back up. It should always circulate within the stomach with its own motility. An interdigestive state. Now, listen to me, interdigestive state, which is between the swallows. This sphincter should be closed. Excuse me. This sphincter should be closed completely. So, but if this is open and there's no swallow, then guess what's going to happen to this fluid? It's going to go back up. So that's what the definition is. American gastroenteritis is a symptom, or actually a disease, which causes these to do that. This is often chronic and relapsing. And I can imagine you understand why is it chronic and relapsing? Because if you have an opening here, which is an anatomical defect and not necessarily, an infection or anything that you can treat, this will stay open. So if you don't manage it, it'll happen again. And that's what the word chronic and relapsing mean, that you have to treat that. You may see complication of the GERD in patients who lack typical symptoms. So I'll give you an example. If you have a little bit of pain in your foot and you ignore it and it becomes normal, and basically you say, it's there and it just happened and it's not severe, and it goes along the business. So acid reflux can do the same thing. If you have minor reflux for a long time, your lower esophageal sphincter adapts to a level where it becomes normal for you. So people sometimes have minor acid reflux and they say, it's part of the normal deal and I don't worry about these, and it can actually become chronic and can cause complications. So people who don't have heartburn can still have gastroesophageal reflux disease and actually can lead to very bad complications. So again, talking to patients, taking a proper history in asking, and people particularly, that does your food from the stomach comes to your mouth? And if the answer is yes, then they have reflux. Whether they have heartburn or not is a two different thing. Frequently they will have a heartburn, but not necessarily. So it all depends who is having symptoms and how severe they're having symptoms. All right, so what is the pathophysiology means? How does heartburn happen? And these are the listing that causes this abnormal reflux. The primary barriers means the mucus that you swallow from your mouth, the water you swallow, the normal mucus secretion of the esophagus that neutralizes the acid is your primary barrier. So even if you have a minor acid reflux at times, there's enough mucus in your esophagus that will neutralize it. But if it becomes overwhelmed, that means there's lots of acid and the mucus is overwhelmed, then it'll start definitely burning it and you'll get symptoms. And that was the primary cause. But then again, you can have a lower esophageal sphincter. The LES stands for lower esophageal sphincter. Normally works in conjunction with your diaphragm. So whenever you breathe, your diaphragm moves and you can feel it. Your belly gets out and in. And that, remember I told you about the esophagus going through the opening in the diaphragm, and that expands and that closes. And that causes the LES to move up and down. And those are physiological way. But if it becomes pathological, it means it becomes larger, then you will have a reflux and it'll stay open. It won't keep the stomach contents down and it'll come back up. If this barrier is disrupted and acid goes back in the esophagus, you're going to have a problem. So more acid secretion in the stomach, the LES is not working. The primary barrier of the esophagus, such as mucus, are not enough, then all these in conjunction will give you heartburn. So, like I said, when you breathe, your esophagus moves up and down, and it can cause some degree of acid reflux, which is managed naturally by your other contents of the esophagus, alkaline content. So if you have acid and you have alkaline, you join together, it neutralizes and it doesn't damage. But then there's condition in which overwhelms, and then your alkaline is low and then acids start damaging, and that becomes pathological. So the physiological GERD, which happens in everyday basis, you and me, are short. They're typically after eating when your stomach is distended, and it causes some degree of acid reflux. And your symptoms gets better after eating, on maybe down the road, maybe a few hours after eating. Some people tend to drink water if they have mild heartburn. and that clears the stomach contents into the stomach and relieves the esophageal injury. And they're mostly asymptomatic. They're not necessarily do that, but sometimes you feel the indigestion, like, oh, I don't feel good because you ate too much. And you ate something that irritated the stomach, and that causes all these symptoms. So all these in conjunctions can cause that. There is a term that we call TLESR. This stands for transient lower esophageal sphincter relaxation. So remember in the first few, in the beginning of my lecture, is that I told you the LES relaxes with the swallow and let the food drop. Now, if there's no swallow and this opens up, this is in coordination with that. Even there's no hernias, there's nothing bad, but it just opened up inappropriately. It can shoot acid back up. And those are transient. They're not everyday deal. So they can cause symptoms. And they are typically transient, and they're not long lasting, and they can be controlled by regular drinking water and all that stuff. And then physiologically, you should not have any nocturnal symptoms, which means when you lay down and you imagine a bottle and you're laying down, the acid tends to come back up, and there's some degree of reflux happen if you eat and lay down. So that's why your parents or everybody else and senior in your family told you to eat and don't lay down. That's not good for you. You should give enough time for the stomach to empty out so that you don't get the reverse of that, and it's not healthy. It puts lots of stress on your heart and your esophagus and other organs. Now, the pathological reflux, which we discussed about, is basically when you get injuries. When it becomes pathological, it means even if you have eaten and the stomach is empty and there's nothing, the acid keeps coming back and it injures your esophagus. And those have typically symptoms of your heartburn, and they have mucosal injuries on examination. And then they have typically night symptoms. Whenever they lay down at night, they said, oh my God, my chest is on fire. And they can't lay down. So they typically use more pillows to prop up so the acid can stay down. But that typically don't help unless you manage your lifestyle and you, lose weight and all that stuff that we discussed down the road. All right, so here's our problem. It's like an iceberg, in our clinics, we don't see everybody with heartburn. Typically, the majority of the iceberg, as you can see in the bottom part, right there, they have heartburn and symptoms of severe disease, but they're doing home remedies. They don't even seek attention. They don't change their lifestyle, and they become very complicated. Then the symptoms get worse. Then they seek their primary care doctors, and frequently they get medications that sometimes helps and sometimes don't help. Because I think understanding the reflux is the main thing, is whether it is heartburn from reflux or it is heartburn from other things. And then that's why some of the people don't respond to medication. And then eventually the tip of this iceberg is sent to the specialist to handle. And that's what we do most of the time. The people who are already on medication and does not help their symptoms, what to do next. So it becomes a challenging task for the gastroenterologist how to handle this further. So again, that's where art comes in, that how you define GERD, G-E-R-D, and how do you define acid reflux and all that medications for that. All right, so I just told you that about the obesity epidemic had really flourished this disease to a level where about 44% of the US adults have heartburn and reflux. Now think about it. We're talking about quite a few people. It's about half the population of US. Think about it. I mean, massive scale. And how much medicine has been prescribed and how much intervention has been done for these people. So it's a very common disease. It's a very prevalent disease. And about 14% of the Americans have symptoms on weekly basis. So one heartburn could be environmental. You ate something wrong. you ate and went to bed, something else was alkaline and burned. So if it happens recurrently, that means they have true acid reflux disease, and that's about 14% of them. And out of half of them have daily symptoms, and they're even more at risk of developing diseases such as your acid damages and strictures and bad stuff down the road. So we'll discuss that. So it's a fairly common symptoms, but then dwindles down to about 14 to 7% of the population that truly has acid reflux disease that needs attention. Again, 7% translates to about 20 million people that can seek attention for that. So it's a very, very common disease. Well, most of the symptoms of acid reflux is fire. Like I said, heartburn is a symptom in which people feel burning in the chest. Now in chest, you have heart, you have lungs, and you have other lymph nodes that performs very important functions. So it can overlap, but typically a retrosternal burning sensation and heartburn is related to your acid reflux disease. That's the most common symptoms. If it's low grade, people get used to it, then you don't get classic symptom. You can still have a very severe disease with no symptoms. Regurgitation is typically effortless. This is return of the gastric contents into your oropharynx, basically. It doesn't cause nausea. You don't have to retch or vomit. It just is effortless, because if you remember the anatomy I showed you, your stomach is under pressure with high body weight or big belly, then it causes the food contents to go back retrograde without any retching or anything that causes nausea or vomiting. So it is effortless reflux. Other symptoms, whenever your esophagus gets burned, it causes reflex symptoms, such as you get lots of water in your mouth, and your mouth is getting ready to neutralize acid. Basically, I just told you the natural mechanisms of acid management is the mucus as well as the watery discharge from your mouth salivary glands. So you start getting this full of water breath that we call. And you typically feel before any vomiting that you get nauseous and you about to throw up, then your mouth is just full of water. And that's the secretion from your salivary glands in an effort to neutralize the acid so it doesn't burn your mouth tissues as well as your pharyngeal tissues. And when it overwhelms, you feel that really bad burning sensation in the back of your throat. The extraesophageal manifestation of GERD or gastroesophageal reflux disease varies a lot. So you have your sinuses that opens up in the back of your mouth. You have the trachea that goes into your lungs. So if your acid reflux is coming here and it's all fluid, it can go into your back of your sinuses or the mouth into your sinuses, or it can trickle down into your lungs and can cause cough. So all these symptoms are extraesophageal. They're not related to acid burns, but you can get reactive airway disease in which the airway is now trying to protect itself from acid. And how it does that, it closes itself. And it causes asthma, as people who have asthma knows how it does. So it causes bronchospasms. There's a term that we call LPRD, laryngeal pharyngeal reflux disease, which is chronic cough and frequent clearing of your throat, such as they do that a lot, all the time. If they're talking, they're clearing their throat. If they're sitting, they're clearing their throat. If they're not doing anything, watching TV, they're clearing their throat. That means there's something irritating that. Whether it's a reflux or it is postnasal drip, it's a question, but you can have that symptoms from acid reflux. And of course, if the fluid makes all the way up to your nose and it goes into your sinuses, now remember, sinuses are blocked. They are not connected outside. They have only one opening. So that fluid can go into the sinuses and cause severe sinuses infection, causes chronic sinusitis. And if the acid is too much in your mouth and the water was unable to dissolve it, it basically causes your dental enamel erosion. So you'll get stains in the teeth of these people, a yellow stain that can cause it. The term dysphagia means difficulty in swallowing, in which sometimes people with long-standing acid reflux says, whenever I swallow, food gets stuck. And that becomes a very important symptoms for the gastroenterologist, because it carries a red flag. And we always worry about these symptoms because some complication has happened. Either it is a scar tissue, something is growing in the esophagus, the esophageal motility that we discussed earlier is in trouble. So there's variable causes, but then again, it's a red flag. So you should always worry about these symptoms and tends to do that. All right, here's a picture of some extra esophageal manifestation that I just mentioned. So look at this larynx. This is front of the larynx or anterior. This is the back of the larynx called posterior. These are vocal cords. And this is where the esophagus starts. So food comes down from this end. There's an epiglottis here. If you remember, it closes down. The food crosses above it and goes into your esophagus. If there is a regurgitation of the fluid, let's say the esophagus, the acid came down up from here, it'll burn these nodules called arytenoids, and it'll trickle above this focal area into your vocal cord and will cause severe laryngitis. And you will have cough and congestion and hoarseness in voice. A lot of people have voice changes because of acid reflux. Here's the picture of teeth with severe acid burns. You can see the peripheral of the teeth is fine, but the middle part called dentine is severely affected by the acid, and the base of the gums are eaten up. So this person has a very severe acid reflux, probably at nighttime when he's sleeping, and he's not getting these. So again, on your right side, I've listed all these symptoms. The interarytenoid changes, what it means is this is arytenoid cartilages on both sides, and this area is called interarytenoids, in which a postnasal drip will happen here, will cause irritation here. But when you have a posterior part of the larynx involved, it's mostly the acid reflux. There can be a subglottic stenosis in which there was acid going down here, and it'll cause narrowing and you will have problem. And eventually, in a very rare condition, can lead to laryngeal cancers as well. Any chronic irritation in the body, whether it is acid reflux, whether it is laryngeal reflux, whether it's chronic, anything chronic can lead to bad things. So that's where your effort is to avoid chronicity and treat that before it turns into bad. All right, so diagnostic evaluation. So heartburn and regurgitation exist in the absence of alarming symptoms. As I told you, people who have had minor refluxes all their life and they ignored it, they basically are danger because an abnormal tissue, fluid is coming and burning. And I just said, chronic irritation will cause problem. So if you can imagine in your head, there's a drop of water falling on a stone, it will bend this, it will make a hole in the stone, even though the stone is so stronger and kind of a compact than water, but water can damage the stone. So similarly in human body, if you have chronic inflammation of any organ, whatever it is, and you don't manage it at time, it can lead to bad things. So silent regurgitation is especially a challenge for us, in which people don't have symptoms. They had symptoms, it went away. And so I sometimes see patients in my clinic who said, oh my God, my heartburn was so bad 10 years ago, and I've taken all this medication, and all of a sudden, without losing weight, without doing anything else, I feel great. I don't need medicine. Well, that's a red flag. The reason is the lining of your esophagus is damaged so much that you don't get symptoms anymore. You need to be evaluated for reasoning of whether truly the reflux was gone and what was going bad, or it is now damaging to a level where now you have more cough problems. So diagnosis can be made clinically, as I just said, and treatment can be initiated just on symptoms. You don't have to do a very invasive test or a very, what we call as a technologically advanced test. You can just listen to the patient, feel that is reflux, and trial a medication and see if that helps. Then your art is to find out who is in danger and what symptoms that can relate to those symptoms. Again, if you remember, we used the word dysphagia means difficulty in swallowing. So if somebody patient-wise says, when I swallow food, it gets stuck, that's a problem. Got to be taken care of. Early satiety means they can eat only half of their meal now. They cannot eat a full meal. They feel full very quickly. So even if they were normal and they have no symptoms and they said, I'm losing weight and I can only eat like half the meal I used to, well, that signifies there's some blockage. A bleeding happens, so people who have vomiting blood is another red flag. The word otynophagia means painful swallowing, and it differs from dysphagia, the first word. Dysphagia has no pain, it's just difficulty in swallowing. Otynophagia means there's pain on swallowing, and that means that there's some inflammation or infection in the esophagus that's causing the symptoms. Of course, ongoing vomiting, unexplained weight loss, and people who are anemic for no obvious reason. That means they've lost blood somewhere. That means they are, in particularly in male sex, when they become anemic, it's a red flag to do further workup, because in females, there's a reason you can become anemic, and that can be put in context. So trial of medication, what do we do on the simple cases? You give them something called proton pump inhibitor in a short term. They're called PPI. And what it does is it closes the cells that makes the acid. So it basically poisons the cell that are forming acid in your stomach, and basically acid is gone. Again, think about it. If there is an anatomical problem and you're turning off acid, rest of the stomach contents can still come. Nobody's stopping that, but acid damages it. So acid gives you symptoms. That doesn't mean the reflux is cured. That means you're removing the damaging chemical that causes damage. Again, you have to educate patients that reflux is still there, but you have to do your anti-reflux measures that we just discussed, as well as take this medication. If the symptom persists when they take off the medication, then that means they have more pathological reflux, such as incompetent lower esophageal sphincter, and they need further diagnosis, which is done by either an upper endoscopy called EGD, esophagogastric duodenoscopy, or you can do a pH monitoring on these patients in which it will detect acid. Endoscopy, as in the right side, you can see we have a very flexible endoscope that actually goes down from the mouth through the esophagus into the stomach. It's a gold standard exam. It's quite comfortable. There's very, very minimal complication, and it gives you some vital informations of this whole anatomy. How is this GE junction looking, the LES? How is the acid looking? How is your esophagus looking? So it's a very smart tool that gives you lots of information for long-term management. Absence of endoscopic feature does not exclude your GERD symptoms. So again, minor reflux in which the acid is temporarily coming up. Remember, esophagus should not see any acid whatsoever. It's an acid-free environment. Any acid there or any gastric content there is abnormal. So whenever they flush down, you will have no symptoms, and then the esophagus appears good. But that doesn't rule out your reflux. It means you didn't catch it at the time where acid was refluxing. Another example of this is if you have chest pain, which suggests heart attack, and you go to the ER and your EKG is normal. Does that rule out heart attack? No. It's just that chest pain is gone, your EKG is normal. Who knows what was the chest pain from? Similarly, your esophagus, when you see it, it's normal. It does not rule out acid reflux disease. You need a biopsy that shows acid damage under microscope, and then you can make a case. Allows for detection and stratification of management of esophageal management. So it will prevent complications and it'll give you lots of information. So upper endoscopy is vital to manage long-term reflux. Other modalities to diagnose acid reflux is 24-hour pH monitoring. This is a very neat tool in which you can put a probe down, and it is very sensitive for acid, and it actually measures the acid. And you don't give them any medication, and patients go on to their usual everyday stuff. They're not changing anything. They're eating normal. And then it picks up the acid, how much acid is there. There's a new wireless catheter now available. It used to be very cumbersome. We used to put a wire and then it was a string attached, and you have a monitor and you go home with a string coming out of your nose. But now it's wireless, since we have everything wireless now. So you put a little monitor here. It has got a Bluetooth activation, and the patient wear kind of a device. It transmits all its data to that device, and we can download in the computer to see what it is. And that particular catheter is called Bravo, B-R-A-V-O. Here's the classic one that I just talked about. Used to be long time ago, which is not done anymore recently. It was very cumbersome as compared to your upper endoscopy, as you can imagine now. You put a catheter to a patient's nose. It has a little catheter that goes down, and it is hooked up with this monitor, and it was going down in the esophagus. It measures the acid reflux, and you measure the acid percentage of time where pH is less than 4. Anything below 4 is acid. Anything above 4 is kind of neutral. As you know, pH of 7 is neutral, and that's not the case in the esophagus. The stomach acid pH is 2. So it's very acidic, very strong acid. But by the time when it comes to the esophagus, it's diluted. So anytime when you have a pH falling below 4, signifies acid reflux disease. And then you have to have symptom correlation with index. That means people can press buttons on these instruments that say, oh, I feel heartburn, and they press a button. And then you have this reading together and see if this truly was an acid reflux when you press the button, because sometimes it's hypersensitivity. Some people just perceive acid reflux and it's not there. So you have to have symptom complex. That means, yes, there was truly acid, and patient pressed the button at the right time, and that you nail the diagnosis that that patient has reflux. Here's the radiograph of that reading that I was talking about. So this line is drawn across pH 4, as you can see. This is a 24-hour reading on a patient. It was started at around 6 p.m. And then you can see at around 8 o'clock, he ate some meal, and you can have a little dip that we call physiological reflux, and it cleared up, and majority of your pH stays above the 4 neutralized range. So this patient does not have reflux or acid coming in the esophagus. While patient with typically up here can see several spikes, and the pH is living around the 4, particularly at the midnight. Look at this hours. Midnight, look at his acid reflux. So he has severe acid reflux when they lay down, and kind of balanced it because acid got shut off in the stomach in the early hours and all that. So this guy has a very severe acid reflux disease. Here's the Bravo I was talking about, which is the modification. This is the pencil, and you can see how big it is. It's just a very small instrument. It is wireless, and we place it in the esophagus right there. It anchors itself. It sends all its signals to a little pager-like monitor that you wear on belt. and it basically reads 48 hours, not just 24 hours. You can do a 2-day study, which is much more appropriate for the diagnosis. Here's what we call as manometry that I talked about. If you remember in the beginning, I told you that the middle portion of your esophagus is responsible for peristalsis, and that measures, so that can cause acid reflux because it's not propagating downwards, it's going back and forth and acid is coming back up. So in this sense, we place a catheter in patient's esophagus. It has several ports which measures the esophagus pressure. So whenever esophagus squeezes, it measures the pressure. And you can imagine the peristalsis is milking. Pressure is relaxation, pressure, relaxation. So it's milking. And here's your pressure changes. So pressure here, and you can see it migrates down in a pattern. And here's your LES. So if you look at your lower esophageal sphincter, it relaxes right here. It was normal, normal, normal. As soon as the swallow happened and food got to your LES, it relaxed. So that tells you the peristalsis movement along with the pH, if there's anything wrong with the esophagus movement. Here's an algorithm that I follow sometime, and it's mostly that how do you treat patients with symptoms. So if you have a person who comes in with an acid reflux disease, he's allowed to take what we call as proton pump inhibitor once daily, has a good response, then you maintain it and symptom persist. You take them off the maintenance therapy, and increase. Let's go back. So good response, yes. Then you maintain therapy with the lowest effective dose. That means if they are on a higher dose, you give them the maximum. Try to take them off. And if the symptoms comes back, that means they have true disease, and that needs further attention. Then you go to this route in which they're taking medicines and it's not responding, then that means they have anatomical defect and they need further management. The other group of medications that are available for acid reflux disease is called histamine blockers or H2 receptor antagonists. These are typically called famotidine and ranitidine, and those are the group that causes less suppression of acid. So minor diseases can be managed by that. So people who are managed here don't need to worry about it. They are in great shape. They can just take medication on demand, but people who are taking proton pump inhibitor and cannot get off needs further attention. Dyspepsia is a symptom in which there's hyperacidity and burping and refluxing. It's different from acid reflux. It's what we call as indigestion. It's a motility problem of the stomach, so you need to differentiate these two, whether patient truly has heartburn or not. It is just listening to the patient and they will tell you two different things, that after eating, my belly's big and I basically become uncomfortable. That's dyspepsia. That's not acid reflux. Acid reflux is actually retrosternal burning. So our goal of therapy is relieve the symptoms, heal esophagus, and avoid complications. Here we go. Main stuff, lifestyle modification. Avoid large meals. You should not overeat. It is not for that. You are a human. You're not an animal. So you should not eat like one, basically. You have satiety. Your stomach sends you a signal that there's enough food. Stop. Don't overeat. And you overeat, you distend more stomach, more incompetence of the LES, more reflux happens. Avoid large amount of acidic food when you have acid reflux. So all these will make your symptoms worse. Decrease fat intake. The reason I say that is because fat slows down your stomach motility. Esophagus is fine, stomach is down here. The fat slows this down and it has more chances of refluxing. So higher fat contents, if you eat a hamburger with lots of fries, it will be in your stomach for a full day. Avoid laying down within 3 to 4 hours after a meal. 2 hours is enough time for stomach to empty out, but people who have had large meals take more time and causes lots of there. Elevating head of the bed is to use the gravity to facilitate gastric emptying and not regurgitation. So all these helps. The medicines, which are smooth muscle relaxers, can relax the lower esophageal sphincter and make acid reflux worse. So all these medications that are used for heart, asthmas, also potentiates the heart gastric reflux, and they need for treatment when they're on that medications. Avoid tight belt. When you tighten your belt and it doesn't fit you, it put lots of pressure in your stomach. Well, guess where all that stomach is going? It's coming up in your chest. So lots of tight clothing, and particularly the models, when they use this corset to make their waist looks great, well, they're not fun. They will cause reflux. So the best thing is not to gain weight. Smoking is bad, strongly related with esophageal cancer, makes your acid reflux worse. And these are over-the-counter antacids, basically for symptomatic relief. There are a bunch of other, they're just neutralizers as that of your mucus in your esophagus. They help to potentiate that. They do not turn off the acid. They do not cure your GERD. They are just symptom relief. This is the picture of acid-producing cell. And I put in there just for you guys to understand how acid is produced. So imagine an acid-producing cell as a pot on a stove, and it has 3 burners underneath it. These are your chemical that makes the acid in your acid cell. One is called histamine receptor. The other one is a hormone called gastrin. And the third one is from the nerve called vagus, called acetylcholine. All these causes acid stimulation. So if you remember, we talked about histamine receptor blocker, that will block only this. These 2 will still be working, and you will have less acid output, but you will have acid output. Proton pump inhibitor, on the other hand, puts a lid on this utensil, basically. So in this pot, if I put a lid on it, it doesn't matter what is here. The acid is not coming out. So there's a very effective treatment for these group of medications. It turns acid off to almost 90% in one dose. Very effective. So people who do not respond to proton pump inhibitor always thinks there's some other etiologies going on, because proton pump inhibitors are very effective acid reducers. They have their own complications that we will discuss some other time, but proton pump inhibitor in itself is a very strong acid suppression. There we go. Histamine receptor antagonist, more effective than placebo. Placebo means it's a sugar pill, has nothing in it. So there was 50% reduction. People felt better, faster healing, and then usually taken on demand. It's not a constant treatment because it gets what we call as tachyphylaxis. You will get used to this medication very quickly, and you will just take a salt if you take it every day. Here's your group of medication, what we call as H2 blockers. Histamine blockers are cimetidine, famotidine, nizatidine. So anything that has dine in the end is typically an H2 blockers. Proton pump inhibitors that I just explained use called PPIs. They are much more effective than H2 blockers. They are much more manageable for severe acid reflux disease, in which there are acid burns and managing. Again, we're treating the burn, we're not treating the cause. People still have reflux, even if you turn off the acid. So you got to educate them that we're not turning off. So if their gastric content is coming all the way to the mouth and they ate a lot, the food will still come back up. It will not burn, but it'll still go to the lungs. So you have to educate them. Here's the proton pump inhibitors available in the United States. There are 5 of them. Their dose is mentioned here. Each one is different with their own dosage, and they work in different way, but apparently some people metabolizes each of them differently, therefore their response is different. Some people do great in esomeprazole, people love omeprazole, and some people love lansoprazole. So it's all metabolism related effect of them, but they work the same way. There's a comparison study of your H2 blockers, histamine blocker versus proton pump inhibitors. The 12 weeks freedom of symptoms, 48%, 77%. Imagine that, significant improvement. The 12-week esophagitis healing rate, which means their actual esophagus was inflamed, is 84%. So significant improvement. Speed of healing is twice as much. Quicker action, rapid recovery, long-term prevention. So proton pump inhibitor really changed the spectrum of acid reflux disease. Optimizing formula. So the way proton pump inhibitor works, if you remember that pot I showed you, whenever it's active, then you put a lid. So the idea to take the proton pump inhibitor is just before meals when your pumps are going to be active. If they're inactive, the proton is not going to work. It's not making any acid. So we tell people to take pill about 15 to 30 minutes before meals, and that's the best time to take it. And if they're not responding well to one proton pump inhibitor, put them to another brand, because I explained you they're metabolized differently in different people. In people who have had large hernias, who are requiring proton pump inhibitors, they are young, they are healthy, then we discuss about anti-reflux surgeries in these people, and that tends to help a lot in managing these symptoms. Anti-reflux surgeries have their own goodness and complications related to them. So we'll discuss it some other time, but that helps in progression your treatment. H2 blockers, symptom control. Proton pump inhibitor, disease control. Surgery, managing the cause of reflux, basically hernias and stuff. So these are the indication in which people we consider for acid reflux disease, in which they require surgeries. They have normal esophageal motility. So imagine if you fix somebody's hernia and their esophagus was not moving well, they can't swallow. Then there's another problem. So esophagitis was proven. There was no complication. They're young and all that stuff. These are the surgeries that we do. Reduces the hernia, repairs the diaphragm, strengthens the GE junctions, so barrier across that. So as I said, managing from symptoms, medications, and surgery. So I'll stop here, and if you have any questions, be happy to answer shortly. I think I have to run to attend another patient there, so more than welcome to ask me some questions.
Hello, sir. Can you hear me?
Yes.
Sir, this is Sandal Aziz from Pakistan. I have a few questions.
Yeah.
Sir, do bad posture causes GERD? I have heard that people who are like studying for the whole day, like I have felt myself that when I study for a long period of time, I feel like a burning sensation in my stomach. So this bad posture causes her GERD.
Tell me your name again.
Sandal Aziz.
Hamdu. So this is your upright posture. There's your stomach.
Yes.
Here's your esophagus.
Yes,
okay. So if your stomach is full, then you bend it. It's not going down. It has to go somewhere. So empty stomach should not give you symptoms if you have normal anatomy.
Yes, sir.
If you have reflux disease, then yes, you will have more reflux in bad posture. So if we end up sitting like this, of course, you're putting more pressure on the belly, epigastric area. You're raising intragastric pressure. So you will have reflux, but it should clear if you have normal defense mechanisms. It should not cause damage or anything. So yes, you're right in getting symptoms, but it may be other reasons that you're getting it. Be something more that I explained you called dyspepsia or indigestion. Might be the more cause than truly reflux. But again, that happens frequently.
Okay, thank you so much, sir. Thank you.
Absolutely.
And thank you for your mentorship and teaching, Dr. Sadiq. I'll begin the Q&A session. So my name is Hamza. I'm a student at the BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine. So to begin the Q&A, I'm just going to ask this question. At what age should colonoscopy screening be started, and does this change if you have a family history of GERD?
Whoa, colonoscopy is not the question of GERD. That's a different question altogether. But the recommendation for colonoscopies to start for screening is now 45. It's not 50 years anymore. We're starting sooner screenings because we are finding colon cancer in early age patients. And that might be translating more because of our diet before our environmental and not necessarily genetics. So the age progression is getting earlier and earlier. So the screening is now done at age 45 in healthy patients. It changes because of family history. If somebody has strong familial cancers, then we check them sooner than that. But in healthy, non-symptomatic patients, we recommend to start looking into colon screenings at age 45 now. And tell me the other question about GERD. Your reflux question?
There wasn't a reflux question. It was just regarding whether the colonoscopy issue would change if there's a history of GERD. But there is another question, separate question about GERD. So when treating GERD, how do you decide if you're going to just prescribe a proton pump inhibitor or an H2RA to a patient?
So it all depends on symptoms, how severe it is, and what is the health of that patient. If it's a healthy individual who is, like the student just asked me, they're sitting in a posture where it's causing acid reflux disease, then I typically try H2 blockers to see what their response is. If it's mild and it goes away, basically that's all it is. You don't need to progress to anything. But if the symptoms are worse, and H2 blockers works like taking a salt, it has no effect, then of course we challenge them with what we call as a 2 weeks PPI challenge, in which we'll see what the response is. If the response is good, they're healthy, they're low risk, they are young patients, then there's no need to proceed to any endoscopic evaluation. You can just treat them symptomatically with low dose PPI. If the symptom persists, whenever they try to get off the PPI, it comes back, and they require higher doses of PPI, then they have true reflux. And you want to understand their risk of bad stuff down the road. You want to see, why are they having reflux? Do they have anatomical problem? Do they have transient esophageal relaxation problem? Or is there some other etiology causing heartburn? So that paradigm goes from symptom control with H2 blockers, progressing to PPI, progressing to endoscopy. It depends on how you are. So most of the time then when I see, they have already tried this. Their primary care doctors have already prescribed them. So I've yet to see a patient who has not taken a PPI. Everybody's on PPI nowadays because it's so safe and everybody wants to take it as a first line. So that's where you basically see that we need a further evaluation or not.
All right, thank you very much. And we'll be asking one last question. So how do you manage your work-life balance?
How do you manage what?
Your work-life balance.
Work-life balance. Oh my God. Oh, well, that was my starting talk. You got to love what you do. If you are made to do this and you hate this, you're going to have a problem, buddy. So do whatever you love. Do whatever you enjoy doing it. Because, I was listening to Madonna's interview one time. You know Madonna, singer, long time ago. She was giving an interview and they said, when do you take vacations? And she said, why do you need vacations? And the question was, well, to get away from work. She said, my work is vacation. I enjoy it so much that if I'm not working, then I have a problem. So again, you shouldn't work all the day, but you should enjoy it. You divide your time accordingly. I give plenty of time to myself and my family. I finish my work decent hour in a day, but during the day I work pretty aggressively, throughout the day. I have no time sitting. So that's how you divide whatever is nice and wrong, wherever you stop. But bottom line is you should love what you're doing. You should not do something that you don't enjoy. So if you are a doctor and you're made to do an engineering work, I will hate that every day because I have no idea what I'm doing. And again, if my subspecialty I do somebody else, I'll be anxiously driven throughout, like, oh my God, what am I doing here? So if somebody asks me to treat a bad infection with an abscess or drainage, I'll treat it, but it's not my choice. But if somebody has a GI issue, I love that. So it's just the tolerance, your acceptance, and what you want to do in your life. That drives everything.
Thank you very much, Dr. Sadiq. These are all the questions that we have for today, and we really appreciate you taking the time out to mentor us today.
Good. Good luck, everyone.
Thank you for your mentorship and teaching. I'd like for everyone to please give a warm thank you to Dr. Sadiq in the chat box for this incredibly informative session. Thank you. So now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz will be for the session is now live. You'll need a 70% or higher to pass and receive certification. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next live session will be Friday, February 3rd at 5 p.m. Eastern Standard Time with a physician mentoring us in public health and policy. Thank you so much for everyone for attending today's session. We hope to see you in upcoming sessions. This concludes this week's shadowing session. Thank you.